and Dr. Thapa sir, Dr. Birendra Mohan sir, Dr. Anurag boss, and my colleagues and my juniors. So first, welcome to the world of Intervention Pain Management Society, our Indian Society of Pain Clinicians. It is the 7th session going on. Now we got the opportunity to listen something about interlaminar approach to the spinal canal by our eminent speaker, Dr. Sushil Jaiswal. And I will first introduce Dr. Sushil Jaiswal something because he is my co-guide also during my MD anesthesiology. And now he's also guiding me from the beginning and also encouraging me. So I'll tell a few words about Dr. Sushil Jaiswal. He is really a brave pain physician, and he did MD anesthesiology from BHU. After that, he started some training of intervention pain management and did own a pain hospital in the posh city of Banaras. And till now, he did at least 2,000 cases of endoscopy spine surgeries. And during this period, he not only limited himself in the needle procedures, he took the brave steps to do all the spine procedures like interlaminar approach, transforaminal approach, vertebroplasty, as well as screw fixation. So 2,000 cases is not a small case. So we got the opportunity to listen from him. He will definitely guide us and make this thing easy. And now I would request Dr. Manish to coordinate the session. And Dr. Manish is did MD from KGMC and PDC
मैं डिस्कनेक्टेड हो गया हूँ अभी फिर से मुझे लगता है वापस जाते हो मेरा मोबाइल लेके बाहर चले गए थे सब उस पर नेट था
Okay,
मैं सुन रहा हूँ मैं वापस जाके फिर से लॉगिन कर रहा हूँ
Okay, and Dr. Manish did PDCC from PGI. Now he is assistant professor in King George Medical College, and he is also interested in chronic pain management. He had won international 4 national papers. So I'd like to request Dr. Manish to coordinate the session. Please, Dr. Manish. Please.
Thank you, Dr. Mandal. Good morning to you all. I welcome you all to the interactive web session on this percutaneous spine endoscopy via interlaminar approaches. And this is a great initiative started by the ISPC for the continuous learning in this period of locking and unlocking. In this series, we are catering many topics from the basics to the practical importance, which all of the pain physicians do and must know. And this platform is to ensure that the process of learning should not stop even during this period of crisis. So I welcome our patron, Professor Virendra Rastogi sir, Dr. Neeraj Jain sir, Dr. Thapa sir, Dr. Mohan sir, Dr. Anurag sir, Dr. Devendra sir, and all the office bearers and all the delegates and members who have joined this session. So today's topic is lumbar endoscopy via interlaminar approaches, and it has to be presented by Dr. Sushil. And many of the things about Dr. Sushil has already been told, but when Dr. Sushil is not busy performing procedures or interacting with his patients, his main interest lies in indigenously developing endoscopic instruments with the aim to further improve upon the spine procedures. And this is another domain of Dr. Sushil. So if Dr. Sushil is there, we can start the session. Dr. Sushil?
There is a little glitch on the side. He's just joining in a moment. Hello, Dr. Aki. Where is Siddharth? Siddharth, are you there?
In the last session, we have discussed various endoscopies via transforaminal approaches by Dr. Siddharth. And in this session, we are going to have interlaminar approaches. It is very interesting, actually. So this session is dedicated only on the interlaminar approaches. So, Dr. Sushil is taking little time to join.
He was here, but he is currently having little technical glitch. So he's just joining in a moment. So in the meantime, Dr. Amitesh, if you can just summarize the what topics we have covered till now, that will be helpful. And unmute yourself. Unmute yourself.
Okay, one thing more, I would like
Yes.
all the members and all the delegates who have joined, so kindly make a feedback of topics they want to learn in the chat section. So we can arrange more topics in the interest of the learners.
I think Dr. Sushil has joined.
Okay.
Hello. Morning.
Yes, sir.
Sorry for interruption.
Good morning, Dr. Sushil. I have already explained about you and about your hobbies, and
Okay, thank you.
so so kindly start the session. Are you ready?
Yes, yes. So just a moment.
Thank you, Dr. Manish, for your kind introduction, and good morning, all the senior and dear friends. Just I am trying to share my screen.
Yes.
May I audible?
Yes, yes, you are audible.
May I audible?
You are audible. You are audible.
Okay. First, kindly allow me share the screen.
Yes, share your screen. You can share directly. You are the presenter. You can share. Martin. Martin,
Yes, sir. Yes, sir.
please help Dr. Sushil to share his screen.
So, Dr. Sushil, you click on the share screen shown and you can see the presentation.
Do I need to remove this slide first?
No, sir. He can just share screen part as presentation.
Dr. Sushil,
Okay, boss.
share your screen.
बॉस वो अलाउ नहीं कर रहा है इस पे मैं डायरेक्ट करके देखता हूँ अगर मैं आपको से अभी मेरी स्लाइड दिख रही है बॉस
नहीं अभी नहीं दिख रही मार्टिन
वो जो शेयर करने का है उस पर मेरा क्रॉस ओके आ गया बॉस आ गया जस्ट अभी दिख रहा है बॉस मेरी शेयर
अभी नहीं दिख रही
हेलो बॉस मेरे स्लाइड शेयर हो
नहीं अभी दिखी थी लेकिन फिर हट गई दोबारा करो
ओके आवाज नहीं आ रही
सुशील आप चले गए हो
मेरे शेयर वाली स्क्रीन पे क्रॉस बन के आ रहा है बॉस
मार्टिन
Yes,
मैं लॉग आउट होके फिर से करूं
मार्टिन क्या करना है बताइए प्लीज
1 minute, sir. I'm just saying, Dr. Sushil, so I can make him present again. Not.
I'm not getting you properly.
I think Dr. Sushil has logged out to log in again.
Yes.
Okay. लॉकडाउन कहाँ है
Hello. I think again he has logged out, sir.
Yes, he's having some technical glitches.
Meanwhile,
Good morning,
meanwhile, I will tell what all topics we have covered till then. So, we should give some 2-3 minutes to Dr. Sushil so that he can fix up. So with the start of this Indian Society of Pain Clinic initiative, we had, this is our 7th webinar. And the first one was about the basics of pain management. The first one was the basics of pain management, and it was covered by Dr. Anurag. The second was about the radio frequency thermocoagulation and the cooled RF and the radio frequency system and the pulse RF system. And after that, we have covered this endoscopy.
Hello.
Yes, sir, we can
Hello.
hear you.
Amitesh, can I see my screen?
No, sir.
You please allow me to share my screen.
Sir,
I allowed you to share the screen. Please go to the Medvis account. From there, click on the share screen.
Martin is saying something. Sushil, Martin, बताइए Martin, दोबारा बताइए.
Yes, sir. Dr. Sushil is to go to the online platform. From there, click on the screen and then his PPT. I have made him the presentation.
सुशील आप प्रेजेंटर हो.
Okay.
हाँ अब आना शुरू हो.
yes.
बट ये होल स्क्रीन आ रहा है अभी.
Sir, please show the PPT. PPT window.
मार्टिन आपकी आवाज ब्रेक हो रही है.
Yes.
अब आ रहा है. यस. इधर फुल स्क्रीन कर दो.
Okay, it's a visual to us?
Yes.
My screen is visual?
Yes, you are.
Okay.
You're on.
I am audible?
Go ahead. You're on.
Please, go ahead. Yes, Dr. Sushil.
Hello,
Dr. Sushil.
Hello, Dr. Sushil. It seems he has frozen. He's again coming back. Some problem with his net, it seems. Coming back. Sorry for this interruption of technical glitch.
Amitesh, you can continue.
yes. So what I was saying, with the second topic was about the radio frequency, about the cool radio frequency and the pulse radio frequency. Then we started the endoscopy series, and in the endoscopy series, the first lecture was by Dr. Anurag and about the basics of the endoscopy. Then the second one was by Dr. Siddharth about the inside-out technique. And this is in the continuation. This is the third lecture, fourth of the endoscopy series, and this is by Dr. Sushil Jaiswal. After this, the endoscopy series will be over. We have decided to have a session on the cancer pain management, and most probably it will be a panel discussion kind of a thing, and to be followed by the ultrasound in pain management. So the next two sessions will be those, and that is the thing.
So now we are starting our session. Dr. Sushil, you are welcome. Please start.
Thank you. Sorry for interruption. Today's my topic is a percutaneous spine endoscopy, interlaminar approaches. Today I will cover the basic to advanced. Today I will mainly cover the video presentation of interlaminar PALD at L5S1, L4-5 cervical, followed by para-PSLD and revision interlaminar. Percutaneous endoscopic spine surgery spine intervention is a very good example of minimal invasive technique. What is the difference between the minimal invasive technique and the conventional technique? Is a target-oriented procedure that relies precise mental projection of pathologic lesion and its relation to the surrounding bony landmark. Minimal invasive technique have been widely used to minimize the disadvantage of open surgical procedures such as smaller incision, less damage to the soft tissue, decreased blood loss, shorter length of hospitalization, and early return to the work, compared with the open technique, but has the same therapeutic effect as a conventional surgery. Percutaneous endoscopic is mainly two types, which I go to cover is a transforaminal and interlaminar, which depend upon the according to the approach to the herniated disc material. As earlier said, told by the covered by the transforaminal by Siddharth, and the instrument and the MRI covered by Dr. Devendra. My main focus is the interlaminar. And the transforaminal approach is difficult to assess to the L5S1 disc space because the high iliac crest, large transfer process, large facet joint, and narrow disc space. What is the high iliac crest? The iliac crest above to the mid L5 pedicles. This can even high iliac crest also will performed by the transforaminal by increasing the your entry is the more medial. Means more perpendicular approach with the possible of the addition of foraminoplasty. You can perform the transforaminal approach in high iliac crest cases. Second option is you can go from the transiliac approaches. The interlaminar approach can escape the blockade of high iliac crest and offer the several advantages, including faster puncture orientation, a shorter operation time, and less intraoperative radiation exposure. The various anatomical features of L5S1 make the interlaminar approach possible. There is a less laminar overhang of L5 vertebra, and the highest interlaminar distance at L5S1 is around the 21 to 40 millimeter. In addition, there is a 3 to 4 mm space between the dura and the ligamentum flavum, which provide the space for interlaminar endoscopic upon entry. Since interlaminar percutaneous endoscopic was introduced to treat L5S1 disc herniation, but it starts a new horizon in the thinking of the endoscopy. Hello, मेरी साउंड मुझे इको हो रही है. Hello, hello, may I do, sir? Hello.
सुशील ईयरफोन लगा रखे हैं?
Yes, earphone. Use earphone.
Use earphone.
मैं ईयरफोन लगाया हूँ, बट मेरी अभी ठीक है. बट मेरी साउंड मुझे इको हो रही है बस.
थोड़ी हो रही है बिकॉज रूम की वजह से हो रही होगी. जिस रूम में आप बैठे हो वहां पर हो रही है.
You can continue.
सेकंड प्रॉब्लम है बस कि मैं कई बार इस पे जुड़ा हुआ हूँ, मुझे उस पे दिखा रहा है फिगर पे.
नहीं
क्या चीज?
सिंगल.
Okay, may I advance, sir?
Yes, you are.
Okay.
You can continue.
Okay. The interlaminar was start with mainly for the L5S1, but after introduction of the interlaminar, it changed the whole thinking about the endoscopic procedure because it's opened the new horizon, and the almost all procedure which can perform by the conventional open surgery is performed by the endoscopic procedure. Almost, not all but almost all procedure with the changes in the generation of the interlaminar, first generation, second generation, third generation, fourth generation. Okay. Now my question is which specialty perform the maximum number of the interlaminar procedure or interlaminar percutaneous procedure? If you think that neurosurgeon or the orthopedic surgeon or pain physician are doing the maximum number of interlaminar procedure, you are wrong. The highest number of interlaminar percutaneous procedure performed by the anesthesia people, like a epidural procedure. Epidural is a percutaneous interlaminar, one of the best example of the minimal invasive percutaneous spine intervention. It's the same like a interlaminar percutaneous endoscopic lumbar decompression. You perform the epidural in the median and paramedian. Paramedian is the same, follow the same principle of the percutaneous spine intervention. You perform a epidural like you're putting, somebody is performing in a lateral position, somebody is performing in the C-arm guided. The people who perform the C-arm guided, they can know the basic of the interlaminar procedure. The basic is the same for PELT, interlaminar PELT, and the epidural procedure. In an epidural and a paramedian approaches, you go like a skin, fascia, then muscle, and the last portion where you stop is the ligamentum flavum. Ligamentum flavum is the most important anatomical structure for all percutaneous procedure of interlaminar root. Okay, then you puncture the epidural spaces very slowly and you find the epidural spaces. Same, I will explain how you can perform the interlaminar percutaneous endoscopic, like your every procedure, every step you perform in a paramedian epidural in the SIAM guided. Okay, every procedure requires some instrument, but I percutaneous endoscopic lumbar decompression interlaminar, I use the term only interlaminar. So it's become more easy to explain. Okay, every instrument requirement same as the transforaminal, except few is the Carrison Ronger, interlaminar endoscope, and the burr. Endoscope of transforaminal interlaminar is a slight difference. Interlaminar scope is a short distance, short length, and the working channel is with a few differences. Today learning objective is describe the phase of interlaminar, apply strategy for efficient progression of imaging, palpation, and visualization. Like in epidural SIAM guided, you put first your patient in imaging, then palpate the structure and then visualize the structure. Apply strategy to gain access to the principal anatomical landmark, recognize possible complications, and discuss how to avoid and manage them. For simplification, I divide the interlaminar procedure in the phases, like a pre-operative planning, operative room, plan, approach, trajectory. I will explain one by one. The first phase is a pre-operative planning. You think before going to the procedure, has the patient undergo sufficient conservative therapy? He has taken the medication and all the conservative method. Is the pathology consistent with the patient symptom? Is the symptom is a match with the MRI finding? Is there any diagnostic workup that would further strengthen the diagnostic? Means you perform the diagnostic block. Is the pathology amenable to interlaminar approach? Like lower lumbar segment is a more easy to from starting to interlaminar approach. You can perform any level, but starting with the lower lumbar segment because there is a wide interlaminar window. Is there any stability or severe sclerosis? Then your plan will going to change. Were there any previous surgery? If there is any previous surgery, there is going to the scar in the track. So you would alternative approach to better suited like transforaminal or open traditional procedure. Now operating room or operative setting same as the transforaminal except few differences. Few differences is in a transforaminal requirement of flexion and only at a hip, but in a interlaminar so flexion is both at hip and knee, because when you flex your knee, then your epidural space is going to increases. Key step in a operative room, patient is under regional or general or monitor anesthesia care. Patient in a prone on a radiolucent table, and kyphosis is induced by the Wilson frame or pelvis thoracic rolls. Obtain AP in-plate view at caudal index level. Center the spinous process and the disc space. Same as you perform in the transforaminal. Here is the how to prevent the lamina coming in your track. Like you put an epidural, like a lumbar region, you put an epidural from behind lower side of the caudal side of the target area. Same as the here. Adjust the SIAM for interlaminar approach. First AP in-plate view of the superior end plate of the caudal index level. Here is the example of for 3-4 level. The addition of the distal tilt. the rostocaudal X-ray beam angle move the projection to the superior spinous process space rostrally. Means first you like this. First your patient first view like this one. Then after you tilt your CR in the caudal direction. For upper level is the 5 to 10 degree and the for lower level is the 15 to 20 degree, because it can prevent the laminar bone in your tract. So you can minimize the bone obstacle and minimize the drilling of the bone. Adjust approach trajectory for migrated disc herniation. For non-migrated disc herniation, standard approach, which I explained for previous one, and for caudal migration disc, your incision is a more cephalic, and for rostral migrated disc, your incision is a more caudal. Like this, I example like this. This is the L5S1 disc prolapse. This one the no migration here. So your entry is like this one. Like in you think your epidural injection, your first entry is just below this one. And when your disc is caudal migrated, your entry is like some cephalic, entry from cephalic and go direct to the caudal migrated disc. For cephalic migrated disc, your early point is this, and now you go from some caudal and directly go to the up migrated disc position. Like this one in a L5S1 mainly, here is your disc migrated in caudal direction, so you go directly to the axilla. And here your disc is migrated upward, so you go direct to the shoulder of the disc. Now imagine how to your first image is this, and your entry point is infero-medial edge of the lamina with the image intensifier. This one. For L5S1, you first square this area and then your entry is from here. For like this one. First you put a middle line and then you put a horizontal line and then you put your target point. Now, first your incision with the 11 number blade, advance serial dilator onto the target area, or you can use the needle and guide wire and they go for serial dilator or single dilator. Palpate and dissect the target area. First your target is infero-medial end of the bone or just middle to the pedicle, and then you introduce your dilator and then place your working sleeve on the target area. Bevel facing medial. Now this one, there is a 2 times rotation. First time you rotate above the ligamentum flavum, and second when you go inside, then the second rotation. Here is the first dilator at the pedicle, and the first your sleeve is rotating, showing the lateral edge of the pedicle. Now you rotate your working sleeve in a medial and seeing the medial portion of this cavity. Now direct visualization of the landmark. After clearing all the fat and fascia upon the ligamentum flavum, you can identify the yellow ligament, its principal anatomical mark in ligamentum flavum, and then the bone mark of the superior lamina infero-medial margin, like this one in inferior articular process, medial to the pedicle area. And there is a at L5S1 no requirement of the medial fasciectomy, but above the L5 you need to first bone work, then before opening the ligamentum flavum you perform the whole bone work with the help of the diamond burr and the Garrison plunger. Then enter the epidural space. Use micro punch to cut the yellow ligament. Yeah, you can prevent the cutting of the ligamentum flavum by separating the ligamentum flavum and coagulate the epidural vein if there is any bleeding. Okay. Identify the lateral margin of the neural element, like this one. Except the axilla approach, this one, there is no need of the lateral margin of the neural element. Retrieve the disc sequester via the axilla or lateral margin. Key step: retrieve the disc sequester either via the axilla or lateral margin of the traversing loop by initial decompression. Medialize the traversing nerve root with the blunt dissector and advance the working cannula into the spinal canal. Bevel facing medially. Now you rotate your working cannula 180 degree and it's work like a, your sleeve is work like a nerve retractor. This is the revision of the interlaminar. If you try to remember as much as you possible, because I am going to repeat it 5 times minimum in my operating procedure. Okay. So there is a approach difference between the endoscopy is the posterolateral or transforaminal and interlaminar. First, the approach difference is that the posterolateral means transforaminal or transaxillary, and the interlaminar is the trans-shoulder or transaxillary. It's the mainly at L5+1 is the trans-shoulder and transaxillary. And the benefit of the posterolateral is there is a spare of the ligamentum flavum cutting, and interlaminar the resection, the requirement of resection of the ligamentum flavum. But you can spare by the help of the separating the ligamentum flavum. Annulus repair is the impossible in the posterolateral, but it's possible in the interlaminar approaches. Indication of the transforaminal is limited, but interlaminar is a wide. You can perform all the procedure which is performed by the conventional surgery. And the main changes of the thinking about the endoscopy is occur after the advancement of the interlaminar. And now every people thinking to the who is performing the open conventional procedure, they also thinking about the endoscopic procedure after the development of the interlaminar. The adhesion in the posterolateral is weak. You can repeat your procedure in many times, but in interlaminar there is a weak adhesion or strong. If you without cutting the interlaminar, you can if you enter the ligamentum flavum, then there is adhesion is very less. There is a two main difference in the L5+1 is the shoulder approach and the axilla approach. Shoulder approach is a learning curve is short, and the axilla approach is some moderate. The downward and the which cases you go for the shoulder approach and which is the axilla approach is the in a downgrade migrated shoulder approach is a very difficult, but in a is the axilla approach is a very easy. And the upward migration disc is the shoulder approach is a easy, and the axilla approach is a difficult. Nerve retraction is a very hard in a shoulder approach, and there is a no or weak retraction at the nerve in a axilla approach. Annulus sealing is a difficult in a shoulder approach and is easy in a axilla approach. Now is the MRI showing the difference between the axilla and shoulder approach. This case is a lateral disc. This is the case for the shoulder approach, and this is the central disc or paracentral disc. This is the EG with the axilla approach. Now your shoulder approach is showing like this. Go to the shoulder of the S1. There is a two types of interlaminar, contralateral and ipsilateral. I will, if time permit, I will explain in the end. Okay. Here is my some few cases of the L5S1 interlaminar endoscopy. It's a 34-year-old male presented with the low backache with the right radiculopathy. May I audible, sir? Hello, may I audible, sir? There is a pin drop silent. हेलो रावती मैं सुनाई दे रहा हूँ
सर सुनाई दे रहे हैं आप सुनाई दे रहे हैं
ऑडिबल
सब लोग म्यूट हैं
ओके थैंक यू This is the MRI of a 34-year-old male showing the L5+1 disc in a sagittal view, T2 image. This is the axial image showing the disc prolapse in the lateral recess area. So my plan is a shoulder approach. Why cannot you approach with the axillary route? Because it's the lateral recess disc. In the beginning, you can always start with the shoulder approach. After you perform some more cases, then you can go for the axillary approach. And putting my needle is the in between the pedicle and the spinous process. And in this picture, in the lateral view, your sleeve or needle is just outside of the lamina. किसी के बच्चे को पढ़ाने की आवाज आ रही है पीछे से. Hello, this is the ligamentum flavum. I first prepare the ligamentum flavum and slow and cut ligamentum flavum in a layer. This is a 3 to 5 mm thick ligamentum flavum. To cut, first cut it 1 or 2 mm and gradually you cut the ligamentum flavum. This is the thicker side. Then here I go to the lateral to the recess area. This is the epidural fat from the lateral recess area, and I clear the dura from the lateral recess. And first, I remove all the adhesion from the lateral recess area to free the thecal sac before medialization. Okay, this is my disc prolapse. Okay, now use the hook to medialize the thecal sac and use your bevel to rotate 180 degree to make as a sleeve as a retractor, neural retractor. Okay. Now this is the interlaminar case at the L5S1 is the axillary approach. This is the 25-year-old male carrying the lower back pain with the bilateral lower limb radiculopathy. This is the huge disc is the central and paracentral area and involving the bilateral lateral recess. Where there is an option to bilateral recess, I always prefer to the left side. This is the T2 image of the axial view. This is the huge disc. And one more thing. And the slightly caudal migrated disc. So my approach is an axillary approach. Needle is in the lateral view is the just lateral to the lamina, and in the AP view just is the middle to the pedicle and the spinous process. There is a center. This is the axillary view for shoulder. Here your entry. This is the S1 and this is the main trunk. And you remove the disc directly from the axilla. मैं visual notes को हटा दूं. In the axillary method, you can remove the huge disc from central. You can free the fecal cell with the blunt dissector. Okay. There is a desk on the other side also. This is the third case. This is the okay. This is the interlaminar case of the L4-5. It's the 32-year-old female presenting with a low backache with a bilateral radiculopathy with a bilateral lower limb weakness. This is just like a impending cardiac syndrome. Huge disc is the at L5 with the caudal migration. This is the T2 image, sagittal view. बोलने का स्पीड बोलने का स्पीड कम कर इधर कैसे रुकेगा the axial you have the huge disc almost covering the all the spaces spinal spaces. My entry is just lateral to the just intermedial margin in the lateral view is the just above the lamina, and in the AP view is the at the inferior medial margin of the upper lamina and just medial to the pedicle. Okay, see the place of the sleeve is just medial to the upper level. The difference between level above the L5 is first you perform the all the bony work before cutting the ligamentum flavum. Ligamentum flavum is our friend which prevent the any further injury to the any neural structure. So always perform your bony work before cutting the ligamentum flavum. This is clear the soft tissue from the bony margin. This is the lateral margin. This is the medial margin. This is the cephalic end, and this is the caudal end. From the bony work with the diamond burr.
ठीक है सर अच्छी पूरा ऑफ कर रखो
Why this is required? To increase the interlaminar space for your endoscope. The upper lamina and the inferior articular process medial portion. And the remaining thin bone is removed by the calcium. Now I start removing the ligamentum flavum. And lateral to the neural sheath. And directly remove the disc, which is a chin. Try to minimize the retraction of the nerve as much as you can. So you remove the disc material which is visible, directly visible before retracting the nerve, and then after you start retraction. This is a huge disc, caudal migrated disc. Using the blunt dissector to retract from thecal side. This is the this is the cephalic. This is the lateral end and this is the medial. This is your caudal end, this is the cephalic end, this is the medial, and this is the lateral. Now you can use your sheath as a retractor. And I am showing the caudal side. This one. That is your thecal side. This is the 8 mm scar. You can perform all the interlaminar procedure in a epidural analgesia. After surgery, the 1 hour after the surgery. The 50% of the radiculopathy and the weakness is the correct in 1 day. Presented with the cervical pain with the left upper radiculopathy with the butt type. The T2 image of the cervical region is the so the disc prolapse at the 3-4, and the axial is the central and the involving the paracentral area. So one of the challenging case from the posterior cervical, because the posterior cervical mainly used for the foraminal disc. Your entry is the same like in a lumbar region at V point, and between the lamina. And start drilling like any procedure, lumbar procedure, start drilling from the lateral to the medial. First clear the soft tissue from the bony margin. Is the upper lamina, is the lower lamina. Drilling mainly the upper lamina and some medial portion of the facet joint, and then the some more, little more from the inferior lamina. Remove the thin bone with the help of the Carson punch. Separate the ligamentum flavum from with a blunt dissector. Because the central disc, so I can perform the percutaneous stenotic cervical decompression. The bilateral. Okay. Now you go for the disc from the axilla. First you try from the axilla. This is the axilla. This is the axilla. This is the exiting root. Minimum retraction in a cervical area. Same. One more thing, here you cannot use your working sleeve as a nerve retractor. So I use a 3 mm retractor which is made by me to minimize the retraction at the nerve root. This is a 3 mm retractor which is made by myself. Is a C3 and this is the C4. Presenting the epidural analgesia. So just immediate in a OT room. We can move here forward. Central disc is a contraindicated from posterior, but you can go from the very slowly and first you remove all the ligamentum flavum from all the sides to decompress the thecal side. Then you can remove the disc as much as possible without traction the nerve. Now there is a two more case, the revision of interlaminar at L5S1 and one para-PSLT. What is the difference between the fresh case and the revision case? In revision case, there is going to the adhesion, mainly at L5S1 because there is a only protection is a ligamentum flavum. Because the beauty for first case and in a virgin case is the highest gap of interlaminar at L5S1 is about 40 mm. But in a revision case, is the going to that area, going to adhesion with the thecal side. So your entry is a more lateral. First try to the bony mark and then go slowly because there is no any ligamentum flavum in the central area. So you can reach at lateral side to find the some ligamentum flavum. This is the my same patient which I saw the axillary approach. This is the second MRI. See, this is the in earlier it is a huge disc, but now only the lateral recess is involved, but the central disc is small. If you want to see the previous one MRI of this patient before the first interlaminar, this is the first MRI before first procedure. Is the sagittal view, huge disc, and there is a central disc, huge disc. But the second time patient come to me and there is some burning and some radiculopathy. So I decided to perform the revision of the interlaminar at L5S1. Now the changes, the disk is gone. Now my entry is just lateral. Now my entry is almost lateral, as the pedicle or inferior articular process are just inferior-medial the superior lamina, because here the ligamentum phlegm is absent. So I first reach at the bony landmark. In the lateral, it's just outside the lamina. At inferior-medial of the lamina. And go very slowly in the revision cases, because your friend ligamentum flavum is absent in a central portion. This is the bony mark. This is the bone. The lateral margin is a bony area. Go very slowly and gentle. Now start drilling some lateral margin of the and facetal and medial part of the facet. So find the some ligamentum flavum. Very slow and gentle. More opening in the recess area. So you can find the some ligamentum flavum. Because my planning is a clear the bilateral lateral recess. And there is a adhesion. This is the main thecal cord and here is the adhesion. very slow. Here's the main trunk and here's the adhesion. Because here the ligamentum flavum is absent, then the muscle is adhesed to the main trunk. And some disc fragment which is a left inside after the and at previous surgery. Okay. This is also the revision of the interlaminar at L. No. This is the case of the 60-year-old male with the severe right radiculopathy, which earlier performed the transforaminal procedure, but the patient present with the radiculopathy in the right side. And see the T2 image. Here is the exiting route. My plan is because the SCP removal to the internal is very difficult, so you go directly to the outside, or you can try with the transforaminal. But transforaminal is the paraPSLD is a difference mainly. In a paraPSLD, you going to the directly to the ligamentum flavum, and then you remove the SCP, and then your nerve come in your track. And in a transforaminal, if you go to the directly to the exiting root area, you can damage the DRG. So I might plan to paraPSLT to this patient. This is some differences in the paraPSLT. ParaPSLT you go directly to the this area, and then transforaminal you go directly same the exiting root area. Okay, my entry is at the isthmus and just below the pedicle transfer process and the SCP tip. Here is my entry outside the interlaminar area, so it's called a paraPSLT. And clear the all the adhesion, then you drill the SCP tip directly and some isthmus. It's a targeted surgery. So you target your exact anatomical structure and the exact pathology. And this is the ligamentum flavum. Perform the all bony work before cutting the ligamentum flavum. And I remove the ligamentum flavum from the axillary area. This is the SCP tip which I have cut, and then the and there is the this is the SCP I have cut, and this is the isthmus area. Then the epidural fat, your main trunk, and here you go to find the exiting route. L5, and here's the main trunk. This is the disc. This is the foraminal portion of the disc. So you can tackle the paraphyseal, the foraminal and extraforaminal disc. The people who is only perform the interlaminar, they don't know about the transforaminal, they can perform the foraminal and extraforaminal disc through the paraphyseal route. In the conventional surgery, they remove the whole the facet, but in an endoscopic, you no need to remove the facet joint. You only remove the tip of the SAP and the some portion of the isthmus. Okay, thank you. So I stop my sharing. Hello.
Hello, sir.
Okay.
Dr. Kruti Sungar Mandal is coming online.
Yes. Thank you very much, Dr. Sushil, Jaiswal boss, and really interesting. But in between, there is some problem in network. There are some questions from audience. One question is there: from which book you have learned this procedure?
From which group?
Yes, which
Everybody
book
in
you are following?
India. Okay, everybody in India, where I remember everything, you transfer every pain procedure we learn from the Dr. Veerastogi. He is our pioneer pain physician and our father, our father in a pain field of pain. All percutaneous procedure, and also I am a MD also in his tenure of headship. I also completed my MD from the uh, under Dr. Veerastogi. So I am keen to learn the pain at my MD duration. So I
And
learn
this,
all the pain procedure from the Veerastogi and the transframinal from the Dr. Gore, and interlaminar few of my friend and some international faculty.
any
Para-PSLD,
newcomer?
I never seen anybody doing in India. So I think this is the first one, but maybe anybody can perform. This is a very easy. Where you go, because I earlier told that the anesthetist is the first person who performed the percutaneous interlaminar procedure in a history. The highest you perform, you know where is the ligamentum flavum. Even you can perform blindly. So, in the help of fluoro, you can go more easier, and then the help of the endoscope is to become more easier.
Okay. For the interlaminar approach, is there any PDF or anything you can share? Interlaminar approach.
Okay.
Any paper or anything you want to share?
Presently, I don't have share, but I can share on the Facebook and my own society, ISPC. I can share the material.
Dr. Anurag sir, you are not audible. You are still not audible, sir.
Boss, next
I also
question is.
forget to mention that Dr. Neeraj Jain, I have learned the vertebroplasty and high end of the painful procedure.
We're going to learn interlaminar from you now.
What is caudal index level? Dr. Jaiswal, what is caudal index level? Caudal index level. You mentioned caudal index level.
In squaring, there is a two end plate, upper and lower. Lower end is the caudal index. Like in L4-5, 5 is upper border of the 5. Upper border of the 5 is the L4-5 or upper border of the 5 vertebra. It's the caudal end plate.
Caudal index, Dr. Sushil, you rightly said, is the caudal part of the index vertebra, the first vertebra, upper vertebra, the caudal part of that. That's caudal index. And I also take advantage. The other colleague, the surgeon, as I told surgeon, neurosurgeon, orthosurgeon, they can also go directly to the in a L5S1. They can directly go to the axilla. So you can also go to the axilla. It is very difficult for them, but it's for your easy. You can go in a directly without giving any sedation and some use of Butyrum and some, and you could directly go to the axilla or upper border of the S1. So you can direct go to the needle and then the guide wire and then a dilator, because your patient in a epidural analgesia, so patient can complain if you injure the any nerve. Mandal, are there any more questions? Dr. Anurag, you're not audible. Dr. Anurag, you're not audible. You're mute. Dr. Anurag, we can't hear you.
Hello. I think Dr. Mandal is again being disconnected. Another query is how to make hip flex while positioning. Dr. Sushil, can you help in this?
Pardon? What is your question?
How do you make hip flexed while positioning?
Okay, you use the rolls at the hip area, then it's going to the flex at the hip. So you increase the interlaminar spaces, and at flexion at the knee, then your dura is the shift in the anterior. So your epidural space, posterior epidural space is going to increase in epidural in interlaminar procedure, but in a transfemoral only flexion at the hip. You got my point?
Yes. Go on, sir.
Okay.
Dr. Mandal, you have to unmute yourself.
Boss, another question is that can you perform interlaminar approach in grade 1 listhesis?
Yes, you can perform, but after explaining the patient, it may be required a further percutaneous fixation. But the grade 1 is not a contraindicator for the interlaminar procedure. Okay. Even grade 1 plus, not the 2, you can perform with the explaining the patient. It may be required in the future, you need the fixation.
But you do dynamic X-ray and see whether there is mobility there or not. If it is fixed, fixed listhesis, no problem. If it is
no problem.
Listhesis,
yes. Thank you, sir.
Dr. Jaiswal, if you will do axillary approach, then what is the precaution you will take for the newcomers? What is the precaution you will take for axillary approach?
My suggestion for newcomer, start with the interlaminar shoulder approach. When you do some work in the shoulder approaches, 10 cases or 15 cases, then your eye
your eye can see which you know. Yani you are, you are more familiar to the shoulder, axilla, and the thecal side. Then you can perform the axillary approach. So try to become the more familiar with the shoulder approach. Then you can go directly to the axilla approach. Even axilla approach is a more easier, but it requires some expertise.
Okay, thank you, boss. And Dr. Manish, just any queries or anything? Dr.
Yeah, there
Manish,
is one. May I, sir? There is one more query regarding for epidural anesthesia. What is the amount and concentration of local anesthesia do you use?
Okay, it's depend upon where is your target area, where is you want to decompression, anterior or posterior. The lumbar canal stenosis, you can epidural analgesia, even 0.5% is a xylocaine is a perfect. For anterior epidural disc procedure, there is a requirement. If there is any requirement of retraction of the nerve, is the 1% is a requirement.
Can you repeat it once again, sir? Slowly.
For lumbar canal stenosis or for central stenosis, your 0.5% xylocaine is sufficient because there is no any requirement of nerve root retraction. But in a anterior epidural space like discal procedure, you require 1%, mainly for the shoulder area.
Another thing which determines is you don't want a motor paralysis. You always look for a sensory analgesia. So that differential block has to be thought so that your motor function, if any time you kind of stimulate the nerve, you can see the motor twitches. So that's another thing which you look at.
Okay. Fine. Thank you. Dr. Mandal, you can take over.
Okay. Another question is there. In case of para PSLD, yes, para PSLD, is there any chance of spinal artery injury? Because dorsal root ganglion, there is spinal artery. So, is there any chance to injured spinal artery? Dr. Jaiswal?
Dr.
think
Jaiswal.
Dr. Jaiswal is not there. They disconnected, I think. Sir, can you explain? Dr. Niranjan, sir?
Yeah, see what happens is you're very right. The artery is coming next to that, and you have to be careful when doing this job. You always don't go too anterior. If you go too anterior, there are things which is called you can get into the paraspinal area whereby you have your hydrodilatation which happens. So there have been cases of a large even hematoma infusion or hematomas or fluid effusion in the irritoperitoneal spaces. So it's always said when you're going there, you have to stay somewhere in the posterior, right on the bone. Don't leave the bone. Stay on the bone. We are doing all this burring and all. If you're next to the bone, you're not doing any hydro injury or you're not doing any hematoma or vascular injury. Definitely that risk is there. So you have to be very, very calculative. As soon as start doing late anterior, if your burr slips over, then you are likely to do an injury to the root or to the vessel, especially the artery, which is more worrying, and it might get into the irritoperitoneal space where you may have a fluid collection in there. So those worries are there. So that we have to be careful. Yes, it is a very good technique, but again, this is meant only for the people who are expertise in the transphenomenal and interlaminar. Only then you go para-PSLD. Para-PSLD comes late in the learning curve, and it's to be done with the experts only. But by the time you come to the para-PSLD, you learn all these intricacies. But don't start with the para-PSLD. That's a worry. That's something one has to be careful about. Para-PSLD is for people like Sushil and people already learn interlaminar. They've done 15 interlaminar, now they go para-PSLD.
For a higher level lumbar region like L2, L3, L3, L4, can we do interlaminar approach?
Yes, people have been doing. They are doing. Like transfer sometimes becomes more difficult when you go in the upper levels because your the interlaminar, the transfer window is wider, the canal is dura is thick. So sometimes people try to do but again remember when doing this procedure, bigger the disc, better it is interlaminar. Smaller the disc, better it is transfemoral number one. Bigger the disc, more dorsal the disc, better it is interlaminar. So those things have to be looked at. If the disc is already looking out at the interlaminar, it becomes a cakewalk. You just go inside, open the ligamentum flavum, take the disc out, and that's all you have to do. If you are expertise, then you go do a annuloplasty, annular work also. Otherwise, that much is enough. That much is enough. Definitely, you have a point there. If the disc is enough and it's not pushing the dura away, it's not enough pushing the dura away, then it becomes a risk to take the dura off and do your work. Because dura is thicker, there are a lot of roots and all. So this has to be looked at. So people with expertise in the transmural area and the disc is lateral, extraforaminal, then transmural any day is a better choice. Disc is more central or paracentral. People like to do interlaminar. Again, interlaminar is mostly for L5S1, sometimes for L4-5. At the disc, less often we do it because the laminars are thick. You have to do a little more bone work. You have to make a window making first. So that is a lot of bony work which is required. So if your disc is easy, transfemoral area, that's the best option.
Dr. Jaiswal, please tell what precaution we will take for central disc in higher lumbar area, like L2, L3. For central disc, we are going interlaminar. So what is the precaution we will take?
Dr. Sushil, you have to unmute yourself. Dr. Sushil, sorry, you have to unmute yourself.
Okay. My first approach is always a transforaminal in above the L5 level. Only the L5S1, I always prefer to interlaminar, but not is important to always because now I am using the separating the ligamentum flavum. Earlier I cut the ligamentum flavum, so there is a side effect going to adhesion, but now I can separate the ligamentum flavum. So my first choice is the L5S1 is most of the cases I prefer to interlaminar, and above the L5S1, my first approach is the transforaminal. But the interlaminar is a huge indication. And even you can perform by going to become the expert, you can perform the foraminal and extraforaminal with the contralateral interlaminar. If you want to see, I one more video of over the top contralateral interlaminar surgery. How to perform the foraminoplasty without cutting the ligamentum flavum at the opposite side.
And it has got an extra advantage that you're away from DRG, so you're not handling the DRG, which sometimes happens with the transmural area. So DRG, yes. least of the irritation of the DRG or injuries there. With the contralateral over the top with the foraminoplasty, which you rightly said, and you can just do it.
Because you perform all the bony work before cutting the ligamentum flavum. Ligamentum flavum is going to always save you in all the interlaminar procedure.
All foraminotomies or foraminoplasty which you do from outside in, like interlaminar or transmural, is from outside. When you're going from over the top, you're doing a foraminotomy. It is right at the level where there is actually compression. So you're actually handling the compression from the facet bone right there, where exactly is the issue. That's important.
And the interlaminar, you can see the three nerves at the same time. Opposite side exiting root, main trunk, and the same side traversing root. But you cannot see the exiting root from the same side. So very difficult.
Okay. Sushil.
Yes, sir.
Yeah. One question which I actually asked. You need to break the operating table to flex the hips to increase the interlaminar window.
Yes. You can. I always do. I always do the break at the. Okay.
We do not have that kind of table. So what is another option? Anything you can suggest?
You increase the size of the rows at the hip area.
Okay, but that increases the height of your table, so that again becomes a problem while doing the endoscopy. So what do you suggest for that?
Increase your issue. I always use a 12.5 mm length, 12.5 centimeter length of the interlaminar scope. So it's some compensation.
Okay, so you suggest that good quality equipment, specifically meant for interlaminar, should be used.
Yes, especially I have the more than 20 scope right now. The 20 scope.
Okay.
So and all are the every company. You have only the instrument which is required in the endoscopy procedure is the scope. If your scope is good quality, then you can perform all and the rest of all of the instrument I made the endogenous and myself. My whole is made by.
That's wonderful. So, Dr. Manish, you are the coordinator. Please ask any other question If not, if there is any question, please ask in the chat box. It's a wonderful presentation, Dr. Sushil, I must say, and it was
Thank you,
absolutely
boss.
indigenous. There was no copy pasting, and it is something very rare to see in our Indian scenario. I hope that Dr. Jain sir will agree with me on this point.
Very good. Very
Yeah.
good talk, and I think probably because it's enlightening and it's now you for many, so it's an important thing. And especially person who is doing it day in day out, it becomes all the more practical. Straight to
Yes.
the heart. When you do the right
Yes.
work, you come straight to the heart. I think which you said right now is the shoulders they get tired. It's always good to raise your height by taking the stool. 3, 4, 5 inches depending on how much you need. So your shoulders are easy off, and you can do a better interlaminar because you don't want to do something like this. You want to be more natural in your work.
And also use the short length instrument.
Short length
Yeah, in a
instrument.
right indication, it is just 15-20 minutes job, and it's a difficult patient, maybe 2 hour job. Is mostly the knowledge could be 2 hour job, so you have to be very comfortable before you get that. Yeah.
That's
And
wonderful.
at present, from the 5% of cases the interlaminar because it's a very less C-arm exposure.
Okay.
Yeah. Hello.
Yeah, one more thing I would like to point out that Dr. Sushil has mentioned that we anesthesiologists have been trained to do the interlaminar percutaneous approach to the spinal canal. So it is not a new thing for us pain physicians who have come from the anesthesiology background to use this approach. So there is a
And
misconception that
all the squaring and going lower side is he always perform in the epidural.
yes,
So it's
yes.
the same like epidural.
Same like capital. Dr. Sushil, there is one more query from my side. Like when I put my dilator end sleeve, I use
Okay.
the revo spine method, where
Okay.
they directly go with the dilator to the ligamentum flavum under the
Okay.
CM guidance in AP as well as in the lateral position. But
Okay.
I was looking at your videos.
Okay.
You have used first the needle, then the guide wire, then over it the dilator. Please put a word about that.
Because you can use the both the method, but the needle we as known, you are expert in a needle. So our primary, you can expert a needle. Where is your target area? Nobody can become as an anesthetist to put the needle as
Yes.
where you want to put. I
Okay.
can put directly in the axilla. I can put the direct in the shoulder area. Even I can put which much area I going to the cut the till the bone. You can
Okay.
put the needle and the in the facetal joint, and you can but the first before going to the you target your area with the help of the needle.
Help of the
And
needle.
when you put the
But
needle in, always try to touch the bone first. Bone is your friend then. So you always
Yes,
try to
yes, yes.
anchor
Bone
it to
is
the
our
bone.
friend. In the
Yeah,
fluoroscopy, bone is our friend.
bone is your friend. Anchor the
but
bone.
there is one question related to this. When you put like guide wire and while threading the dilator over the guide wire, are there no chances of slippage of guide wire because guide wire is not anchored in any structure in the interlaminar route?
Your guide wire is above the ligamentum flavum. In case you go inside, your patient is in a like epidural anesthesia. It's not anesthesia. So you can, if you not so hurry, you can't damage the neural structure.
Okay, that's great. Another thing I would like to ask, which is I found different in your method, that are you squaring the lower end plate in the interlaminar also?
No.
Because
It's the first I squaring then I tilt the caudal tilt Siam to fluoro image to increase the interlaminar space and shift the upper lamina above the area of the shoulder. So
that is the
I make
squaring, no?
no
That is
squaring
the
is
square.
the
No.
no.
He means
After
squaring for the
squaring,
interlaminar
tilt
first.
10 to 5 to 15 degree depend upon the level. First I square set in the first squaring, then after squaring I tilt the fluoro in the caudal direction.
Okay, you do more than the squaring.
Yeah,
You
so
Yes.
treat
let me
yeah.
explain. Anurag, let me explain. What he's
Sir,
saying
please.
is, first you see the discal thing, you do the parallax removal for the disc
Uh,
area. Now you are doing the parallax removal for the interlaminar spaces like spinous process, like we do for epidural. So he's
yes, sir.
saying first you square for the disc, then you square for the interlaminar. when you do, then becomes off square for the disc. You know, when you do interlaminar squaring,
Yes.
you are trying to see what he's trying to say is you're trying to see the maximum interlaminar window. Like interlaminar is narrow, then you start doing you see the maximum interlaminar window. Where you see the interlaminar to the maximum, that is the area you are going to hit the target. That's your
In easy way, you spinous process, you you remove the spinous process from your skull area. So you tilt the caudal tilt, your spinous process go above the disc level.
Okay.
This
So
helps
one
you
more thing.
in doing the less of the bone work. When you have the biggest window, you have
Yeah.
to do less bone work. You know, that's
Minimum
the whole.
bone.
Because the disc is higher than the lower border of the upper lamina.
Yeah. So one more thing. This is in the AP picture. What about lateral? Do you make the lateral after doing the caudal in the same inclination, or you remove the inclination of C-arm while doing the lateral?
It doesn't matter in which view you're tilting. You can perform in any way. I don't need any squaring and anything in the lateral way.
Okay, that's great. I was asking on the behalf of all the physicians here. Yeah.
No,
In
one
lateral,
thing I would like to.
what was your initial angle? In lateral, it doesn't matter. That's
Lateral
the whole point. Another thing which Dr. Sushil to add to Dr. Anurag what he's saying is when you're doing actually the final insertion at the ligament flavum, you're anchoring it. You should be as blunt as possible.
Yes,
You know, the needle things and all is gone, guide wire is gone. You should be as blunt as possible, just to reach the ligament flavum. At the ligament flavum, it has to be more of a blunt work or under vision work, like you normally do under vision work. That's the whole idea. There have been some technique which they are doing a blunt way, like Choi. He goes blunt with the trocar, get into the ligament flavum, hears the ligament flavum with the trocar itself, without doing any blindly under fluoro, and then puts the scope inside, and then he's already inside the ligament flavum, seeing a full fat. So there are people who are doing it a blind work up till the epidural fat.
Okay.
Not advisable with expert like you, but they are Gunchoi and all they have been doing for ages, and they find it okay because at L5S1 the dura is narrowing, the canal is wide, epidural fat is a lot of epidural fat, so it's a choice people have it. But I think for a person like you, under vision is always a better option.
No,
This is
sir.
the
What
only
I
possible at a level of the L5S1. Above you don't go inside without cutting the bone.
You cannot.
so,
Dr. Anurag, there are 2-3
sir,
points which I wanted to bring to your
please,
kind of,
sir, please.
just and we can discuss on that. First of all, compliments to Dr. Sushil, that he's invented his root retractor, which is very useful tool, very important tool. Otherwise,
Yes.
you'll have too much of dural tears. As it is, interlaminar is defamed because it's causing more dural tears than transfemoral area, and that's a little worry.
Yeah.
So that retractor is very, very important. And number 2, if dural tear happens, just a word, they say up to 8 mm dural tear, you are not worried. It seals by itself. And those micro bleeds in the epidural area, they act as a blood patch, so you don't worry. If it is more than that, you have to use a Tecosil and Durasil or something. Second, Dr. Keel, if there is adhesions by the chronic disc or recurrent disc, or there is a synovial cyst, it's always good to do the blunt dissection first, break away the adhesions before you pull out because cyst may be looking at you, just looking at you, or a disc maybe. But once you try to pull it, there is likely that you injure the dura or tear the dura. So it is always good to do a blunt dissection, separate out, look at the cleavage. If the cleavage is nicely visible, now you take what is your structure of interest, whether it's synovial cyst or the disc fragment for that matter. Very, very important. Recurrent, chronic, and dirty disc. And as I said, the bigger the disc, better it is. Except one case where I have a little different opinion. If the large central disc which is extruded and the cord is right over this overlaying, so it becomes difficult going interlaminar. Sometimes transfemoral area is a better option. You take the central disc fragment because if you try to separate away the dura from the disc, this is too large. Chorda is already there, so it is causes more chances of injury. So that
You can conjoin both the method. First transforaminal. If you are not satisfied, then go to the interlaminar.
Interlaminar, very right. And second is interlaminar is good. It's because the whole procedure is a floating cannula, like we do interlaminar lately. Outside in we're using floating cannula. So you have a floating cannula. You can go upper disc, lower disc. You can really do any migration, lateral migration, medialize. You can go over the top, other side. Some people have used single puncture for 2-level disc also. So it's a very, very good technique, very versatile. I want every pain physician over the time, once you've done transfemoral procedures, learn interlaminar. Surgeons may be starting with interlaminar, going transfemoral, but for us, it is transfemoral first, then go interlaminar would be a wise option. Because you want to have a confidence building measure. The confidence building measure is there. This is very, very important. Then is the facet doesn't come on the way here mostly until it's a bad facet, because which is a problem in the transfemoral area where there's a posterior dorsal fragment. So then becomes a bigger. You do more facet work here. You don't have to do big facet work, and as I told you, less of the PRT issue. And lately, you said that lately people are trying to preserve the ligament of phlegm as far as possible in interlaminar also. There have been times people used to be very wary of the ligament of phlegm. Any bit of ligament of phlegm, they will remove it. They want to see dura through and through from one side to the other side with the roots, traversing roots and exiting roots. But lately, intelligence says you try to preserve the ligament of phlegm as much as possible because less of the adhesion will happen. And imperative.
Mainly at the L5.
Yeah.
Because the upper level, the lamina is very near. Yes.
Yeah, you try to preserve. It's a ligament preserving surgery for the less of the post procedure fibrosis. And which rightly said, always go symptomatic side for the transfemoral area. But interlaminar, you can choose to go. If you want to go ipsilateral, you can go ipsilateral. But if you can always go contralateral from the other side and go over the top and do the work, So the dictum says go from the symptomatic side. Changes in these scenarios when you do contralateral, over the top. And always cautery and then cut. Never cut and cut. Very, very important because then there's a lot of bleeding and nonsense, and then you start pushing. Then the fluid problem comes. The fluid. Yeah, and there's one small word when you're going a dorsal disc, in the dorsal area, dorsal thoracic area. People are doing interlaminar very often, but then you have to be careful. Your water jet, you try to float because to reduce the bleeding. That water jet causes the cord injury at that area where the cord is thick at the dorsal area. In lumbar and there is only cauda and you have a lot of reserve, so that's not a problem. But it's always important people who are doing the dorsal part. And last is which I said about dura 9 mm. There's a few things which I thought I should bring to people's notice, and rest you can always dissect on what I am saying, and you can always kind of second it or say something on this. The word is going to be important.
Dr. Sushil.
Last few words I want to share. In the content disc or exudated disc, above the L5S1, first try transforaminal, and then go for the interlaminar. And the high grade migration is always easy through the interlaminar approaches. So always try to contain and exudated disc with the less migration. Try the first transforaminal approach. So transforaminal approaches are always better than the interlaminar. But as your scenario cases scenario increases, like me, I am doing the lumbar canal stenosis and everything with the scope. So my increase the interlaminar procedure is now increases. And the transforaminal is only indicated for the disc. And some people also comment that they can perform the canal stenosis, but very difficult. When you go into the axillary area, your nerve is your exiting root, and the main trunk is your pathway. So you cannot perform the upper ligamentum flemum in the axilla area. It's very difficult. The people told they can perform the lumbar canal stenosis, the transforaminal is very difficult. It's only possible for lateral recess, but not the axillary area. The one more thing, the take home message is the not the pain physician, orthopedist, the neurosurgeon, who's perform the most percutaneous spine intervention interlaminar. The 2 days a take-home message. Even saying that this forum, you can perform without help of the CRM. You can perform if your CRM is not working. You is the only person who can continue your surgery by the help of the scope and the needle.
Yeah, that's great. Dr. Manish, I think that question have been over. Dr. Manish, Dr. Mandal, so please, I think thanks. This is time to say goodbye to all.
Goodbye to all of you. But one last thing I have to tell you. So both transforaminal or the interlaminar procedures is one who is master of transforaminal can do better in transforaminal. One who is master of interlaminar can do better in interlaminar. So because various studies are there, Those who are master in transfemoral can do any surgery from transfemoral approach, and those who are master in interlaminar can do from interlaminar approach. And the outcome of the pathology lies in the age of the patient whom you are operating, the length of the disease, the lumbopleural pain, and these are the major issues which you have to address, because it has been found that in the more aged patient above 45 or 50, the results of the both procedures are the same, whether it is done from transforaminal or the interlaminar approaches, as well as the length of the disease. If the length of disease is more than 12 months, so there are various studies that have been there. So indeed, it's been a good and nice session, an informative session for all, from the practical point of view and the theoretical point of view, from the stalwarts just like Neeraj sir and Sushil boss. It's been a nice interactive session, and hope we will continue this type of session in the coming weeks. Also. So, is it a time to say goodbye to all of you?
Yes, I think so.
Thank you very much.
Okay.
Thank you, sir.
And we pray more
Goodbye.
innovations, Dr. Sushil, and more instruments. We are waiting for that,
Yeah.
Thank you, sir.
You're taking the lead.
Good.
God bless.
Thank you, Dr. Neeraj Jain, sir. We thank you from the side of Indian Society of Pain Clinicians to bring your come here from your very busy schedule. I would like to thank Dr. Sushil Jaiswal for his amazing presentation. I would like to thank Dr. Manish Singh from Lucknow, who is a very competent pain spine physician by himself, for coordinating the session. I would like to thank Dr. Mandal from Jharkhand, who is also a PDCC from BHU and a wonderful pain physician and doing a wonderful job in a very remote part of country. And it is very heartening to know that some very advanced branch like pain medicine, which is still emerging in large part of world, is being provided and taken care of chronic pain patient at the remote area of Jharkhand, which otherwise is not considered very advanced, but it is doing very well in the field of healthcare. So I congratulate Dr. Mandal for doing this wonderful job and providing relief to your patients.
In the
pain is present everywhere.
Yes,
pain is present everywhere, so as the pain physicians.
But not the pain physician. Pain is rightly present everywhere, but unfortunately not the pain physicians are everywhere. But with the formal education and with the efforts of the giants like Professor Rastogi, Professor Dr. Neeraj Jain sir, Professor Gaidu sir, Professor Veer Mohan sir, and also many, Dr. Gautam Das, Dr. Kailash Kotani.
Including you now.
I am still in the second league of you giants. So we are catching very fast with the word. And in the last webinar also, Sir Neeraj Jain sir, you would be happy to know is someone from Arab. He himself is an Egyptian, some doctor who joined there. He told us in our webinar that India is the second country, perhaps one of two in the world, where we are doing all kind of pain medicine spectrum work in large part of the India by the large part of India pain physicians. So this was the appreciation and
one of the Neeraj sir also.
Yes,
Dr. Rastogi, Dr. Neeraj sir, and you are the new generation. You are the master who can carry his.
We are very happy the way you people are doing. We are very, very happy, believe me, and we want you all to surpass us, because
yes,
new heights,
Yes, Dr. Anurag is my examiner in my PDCC exam.
Thanks to Dr. Rastogi sir. So thank you all the audience. You have been very kind and interactive. Thank you Siddharth. मैं कब से ढूंढ रहा था, मैं कहाँ हूँ, तुम दिख ही नहीं रहे थे इतनी देर में, ये पता नहीं. तो खैर we will continue with this effort, a small effort in the field of medicine. Thank you all. So I am stopping this session now, and we will see you next week the same time. Yeah. Okay. Bye.
Bye.
Take care.
Bye.
Take care.
Bye.
Bye.
Bye.